Yeah, I've done that. Okay, so we are being recorded for this talk. Well, first of all, I'd like to really thank the organizers of this meeting, Pat Feddy, who leads the Essex, Chelmsford, South End, PMR GCA UK group so efficiently, and really has done a wonderful job. And of course, Christopher is Pat's absolute right-hand person for all the technological stuff that we are seeing today. So again, thank you very much to Christopher Poole and to everyone in the PMR GCA UK who has shown really so much interest to make this condition have the profile that we have today. And I'm so delighted that through the efforts of the charity, we have over 70 people joining this call. So thank you very much. So I thought that we are really going through very strange times, and I think it is absolutely essential. This is what I have found from my experience with seeing patients and managing their problems during this pandemic, that it is absolutely essential that you really do your utmost to totally understand your condition, your treatment, your management, and of course, a very important aspect of that management is the results of your blood tests, because that is actually such an important thing that comes across every time I review a patient. So, the challenges that we face today, this is part of the talk that I gave for PMR GCA UK a couple of months ago, just to review. Really, we have the challenges of having the PMR and GCA diagnosis. We also are facing the challenge of getting the GPs and other emergency clinicians to appropriately refer our patients to us, to our fast-track clinic, PMR GCA referrals. And of course, there are challenges in terms of PMR and GCA assessments, because we are now not able to see every patient face to face. And many of our patients we are seeing over the telephone, some over video, etc. And that really imposes a different set of challenges as to how we assess our patients. And that feeds into PMR and GCA treatment. So all this really leads to the fact that it's absolutely essential that you become an expert. You sort of become part of the medical team to assist self-assessment, self-management, the communication of your problems, and of course, very, very important now that we are into this pandemic and we are heading potentially for a second wave. I don't think so, but let's prepare for one. And mental health is absolutely essential. So some basics we need to get right. You must take your medications as before. So we frequently get messages that I've stopped this, I've changed this, I've done this, I've done that. To be truthful, it is so important that during this pandemic that you remain well. And our resources for responding to people who are having flares is limited. Therefore, you must take your medications unchanged and do the utmost to try and keep yourself in a good shape. And that is very important, therefore, that you must plan ahead to get your medications. And we are hearing more and more that, Professor, I tried to get my medications, but I couldn't. It wasn't available with the chemist. The prescription wasn't signed off quick enough. So really, we need to be very proactive in getting your medications, having adequate stock of medications at home so that this problem doesn't occur. We need to make sure that all the appointments are kept well in advance, and you're aware whether it's a telephone appointment or a face-to-face appointment. Sometimes people turn up to the clinic and we're not able to see them face-to-face, and that is a huge disappointment for the patient. So you need to be careful about your appointment dates. And very, very vital, therefore, you must know your medications thoroughly, and that is critical. So, we've always felt that you need to know your medications, but now it is very vital that you know your medications thoroughly. And so in some ways, you need to almost memorize the list of your medications so that it's all in your head. So there are a lot of guidance available over the internet, over the websites, particularly the Royal College of Physicians guidance. And certainly that's something that you need to be looking up, in terms of guidance on medications, COVID, remote consultations, going to the hospital when you have a physical health problem, and that's vital. And really how to monitor your health at home, and also, manage day-to-day other things. And we touch upon things like other habits, especially things like alcohol intake, etc. So there is a big challenge about coping with uncertainty, and really how you're feeling about your current situation. What are the fears, anxieties, worries that might be really rising and causing various emotions? And the question, how will the current situation impact on your life and your family? And really, then you have to delve and go back to all your hidden resources to help yourself deal with the stressful situations in the past, and then try and marshal those resources to try and help yourself today. So some basic do's and don'ts. I always believe that you should limit your exposure to the news. Don't have the telly running all the time. And really find a trusted news source and discuss with the family and friends. So all sorts of fake news is coming out in the social media, etc. So try and avoid that, and find a trusted news source such as the BBC or etc. And really limit yourself to some limited news sources. And of course, human nature always likes to blame everyone else in times of crisis. Unfortunately, this really helps. So there is that element of behavior where we try and stop, blaming everyone for the problems that we are in. And of course, no group, race, or ethnicity has any responsibility for this pandemic. We are all in it together, and we need to put in our time and energy together to do what we actually have control over, rather than worry about the things that we don't. And this will help with our mental and physical health. Okay, so remote consultations. Now I'm getting to the nitty-gritty of my talk today. So whenever you have an appointment for a remote consultation, you must prepare. And you must prepare for the review in terms of how you are. You must prepare your questions that you may ask the doctor or the nurse when they ring you, and you should be able to succinctly put forward your problems. And it's quite a good idea to actually write down your problems and your questions. Make sure that the line is clear, and that's very, very vital. And I can see that sometimes we have difficulties, particularly if they're hearing problems, so etc. So do have someone else on the line who is able to hear us very clearly. Make sure you're seated comfortably. And I certainly suggest that put your phone on a speakerphone so that you can seat yourself comfortably, because I frequently ask questions about examination. Do this, do that, raise your arms, move your neck, feel your pulses. And all this is predicated on the fact that you must be seated comfortably. make sure you have a list of your medications right next to you. So the first question that I will ask, or Madeline will ask, or anyone will ask, is what medications you're on. And really, it's a waste of time then if you have to go and get a list of medications from somewhere else. Please do have pen and paper available. And that's absolutely vital, because I will then say, when we change your medications, I'll tell you, are you writing all this down? Repeat what I have just now said, and that's vital. And I find it is very, very useful to have your spouse, your husband, your wife, or your son or your daughter-in-law on the line as well, if you don't mind privacy issues, so that, you know, 2 pairs of ears are so much better than just having you listening to what I'm saying. And of course, now today we are talking about understanding blood results, and that's absolutely vital. So communication is vital. So now I'll get to the nitty-gritty of my talk. So the first aspect of the blood results is to look at the blood count. And when we talk about the blood count, you know, there are 3 different types of cells in the blood. We have the erythrocytes, these are the red cells, which give the blood the red color. We have the white cells, and primarily there are 2 important types of white cells that we discuss in relation to our patients, and that's the neutrophils and the lymphocytes. And the third cell type are the platelets. So the white cells here, they actually get involved with defenses. The red cells get involved with carrying oxygen, and platelets are the cells that are involved in the blood clotting. If you have an injury to your blood vessel, otherwise blood would pour out incessantly, and we have the platelets to make a clot and prevent that. So these are the 3 important blood cells that we look at in a blood test when we are looking at the full blood count. Okay, now we will drill further into the red cells. And the most important for you to remember, if you're going to be able to look at your blood test and make some sense out of it, is that the blood tests in terms of the blood count, actually about the red cells, they tell us about whether the red cells are shaped properly. And the normal shape of the red cell is, as you can see here, it's biconcave, and changes in the red cell shape when it becomes spherical or bloated or thinned are associated with many problems with anemia. So we try and look at the shape of the red cell, and we look at the size of the red cell. So whether the size of the red cell is normal, whether it is smaller, or whether it's bigger. And that tells us about the different causes of anemia. So doctors use, nurses use these jargon, and microcytic RBC means that red cells are smaller. Okay, this is the normal shape of the red cell, and the red cells have become smaller. And quite often, when the red cells become smaller, they also they lose their iron content. They look less red, so then they look pale, and that we call, you know, hypochromic. So microcytic hypochromic, and that is associated with 2 different types of anemia. One is iron deficiency anemia, and iron deficiency anemia is usually due to blood loss. So if you're losing blood from somewhere in your body, usually from the gut, for example, in the back passage, or even if you're losing it from your teeth or your gums, etc., then you get iron deficiency anemia. And when you get iron deficiency anemia, the red cells become small and they become pale, and we refer to them as microcytic hypochromic. What you might more likely do, since I assume most of you have either PMR or GCA, is you're likely to suffer, if you have a flare of your condition, from chronic disease anemia. So the inflammation in itself, whether it's PMR or GCA, will cause anemia, and in which case the cells often remain normal or they become smaller, and this is called normocytic normochromic anemia. So you get chronic disease anemia that can be either associated with a smaller red cell or a normal sized red cell. Another important aspect that I'll flag up is many of you may be on what we call chemotherapy type medications in the rheumatology clinic, whether it is methotrexate, whether it is leflunomide, etc. Now, this has a different effect on the red cells. So this is the normal shape of the red cell, and the red cell becomes larger. And in our medical jargon, we call this a macrocytic anemia. So the red cells have become larger, and that is usually due to your methotrexate or your leflunomide that makes these red cells larger. There are other causes for macrocytic anemia, such as people who take too much alcohol, people who have underlying underactive thyroid disease, so people who have underlying liver disease. So liver disease, B12 or folate deficiency, so are also important causes of macrocytosis. So whenever on our blood tests we see macrocytosis, we check for B12, we check for folate, we check for liver conditions, we ask about alcohol, we do thyroid function tests, and of course many of you will have large cells because you're on methotrexate or leflunomide. So to sum it all in terms of your blood count, we look at the size of your red cells, and if it is small, that is iron deficiency. If it is large, it is usually B12 or folate, and you can also get anemia due to chronic disease. And when you look at your blood test results, you will find a term called MCV, and that means mean corpuscular volume. All it means is actually the size of the red cell. So whether the red cell is smaller or has it become larger. So again, a smaller red cell associated with iron deficiency, a larger red cell associated with B12 deficiency, and people with PMR GCA may not have any changes. We also look at something called the MCH. That is the mean corpuscular hemoglobin, how much hemoglobin there is in the red cell. And if you have the MCH is low, we say it's iron deficiency. If the MCH is high, then that is the other, the B12 deficiency, etc. And then we look at something called the ferritin. You would have had your ferritin checked. So the first thing that we check when you have anemia, and we suspect that you have iron deficiency anemia, is we check your ferritin. And ferritin is basically iron. And if you have iron deficiency, you have low ferritin. Quite often in other causes of anemia, you may get raised ferritin. For example, if you have active PMR or GCA, quite often ferritin rises. So ferritin is an important test. B12 is an important test. We look at the folic acid. The folate is an important test. We also look at the size of the red cells. And of course, all of this is related to the fact we look at the hemoglobin. So anything between 12 and 16 is normal, and under 12 is anemic. Over 16 is what we call polycythemia. So a lot of people who smoke have high levels of hemoglobin. So now I'll come to the white blood cells that we look at in the blood count. And the white blood cells are of different types. The important one is here, this is called the neutrophil, and this is called the lymphocyte. So the two sides, one is the neutrophil, where you can see this is the nucleus of the cell, and you can see this almost crazy, lots of arms and legs here, and that's a neutrophil. And the lymphocyte is exactly the opposite. So it has no arms or legs. And there are other forms of cells here, eosinophils, basophils, monocytes. So the important thing, the function of the white blood cells, the neutrophils, is the important one. And they rise when you have infection. So whenever you look at your blood test and you find that your white cells are raised, and this white cell rise is due to neutrophils, the first thing that we think about is that you may be having a bacterial infection. Okay, so if you have sometimes low neutrophils, that may be due to some other disease, or it may be due to a side effect of the medication you're taking. And that's called neutropenia. So the neutrophils are vital when we look at actually your blood count, whether you have protection against infection or whether they are low, therefore leaving you unprotected. The eosinophils here, this cell, is usually, we look at the eosinophils and it rises in allergic or parasitic reactions. And the other important cell that we look at is the lymphocytes. And the lymphocytes are the ones that secrete the antibodies. And therefore, whenever you have inflammation, you have rise in the increased globulins. And sometimes the lymphocytes, the important is, they might be damaged by some of the treatment that we give, such as chemotherapy or rituximab, and then we get reduction in the B lymphocytes, and you get decrease in your immunoglobulins, okay? So that's something that we look at quite regularly, and these are two aspects of the blood tests that we look at. In terms of the total white blood cells that you have in the blood, the vast majority are neutrophils. The vast majority, 62% of your white blood cells are neutrophils. About 30% are lymphocytes. So I'm just trying to help you, because all this will come up in your blood count result. So when you look at your blood count result, and when you look at your white blood cells, you'll find the neutrophil number 62%, lymphocyte number 30%, monocytes about 5%, eosinophils less, basophils even less. So the vast majority are neutrophils or lymphocytes. So again,
could I just interrupt, Professor, just briefly? Sorry to cut you off in your flow. Could you just check the participants list in the waiting room?
Yeah, sure.
I've had 2 phone calls. People are sitting there.
So we have 73. Yeah, shall I allow them in? Yeah, I will allow them in.
Thank you very much.
Done. They've both been allowed in. We talk about the causes of increase in your white blood cells, and there are some due to your lifestyle. For example, smokers. Smokers tend to have, I hope we don't have too many smokers here. Smokers tend to have a rise in their white blood cells. If you do a lot of exercise, your white blood cells will rise. So if you have a blood test just after you've done exercise and your white cells are raised, you need to tell your doctor or nurse that you may have had the blood test done after a lot of exercise. If you have allergies, that can give rise to increase in your white blood cells, okay? So, and of course, people who are on high doses of steroids, steroids themselves can give a rise to your white blood cells. So we frequently find, for example, when we start people with GCA, new GCA on high doses of steroids, we often find that their white cell count will go up, and that doesn't mean infection. So it's due to the steroid themselves. Of course, a very important aspect is infections. So anyone with unexplained rise in the white cell count, we do think of infection as an important possibility. People, I do apologize for the spelling, this is asthma. People who are having asthmatic attacks, they may have rise in their white cell count. And of course, we find that any form of inflammation which can give rise to change in your white cell count can give rise to inflammation. And if you have tissue damage, For example, if you have any sort of injury, if you've fallen down, broken your bones or damaged your soft tissues, that might also give rise to a rise in the white cell count. And there are, of course, more serious blood causes, which I've not talked about, which the hematologists get involved with, things like leukemias, etc. But that's not very, very common. But these are some of the common causes, again: smoking, exercise, allergies, steroids, infections, asthma, inflammation, and tissue damage, all of which can give rise to rise in your white cells. Very important, of course, if your white cells are low, we call that mainly leukopenia or neutropenia. And of course, some infections, overwhelming infections, actually can cause low white blood cells. And of course, some of the medications that you're taking, such as methotrexate or leflunomide, or some of the chemotherapy type of drugs, can all give rise to low white blood cells. And there are nutritional causes of low white blood cells. And that's, for example, if you have a low B12, then you get what's called a megaloblastic and a low white blood cells. There are some immune diseases like lupus, which can cause actually a decrease in your white blood cells. Sometimes even rheumatoid arthritis, a particular type of rheumatoid arthritis called Felties, can give rise to low white blood cells. And of course, I've talked to you about lupus. Let's talk about platelets. And platelets are very important. So you will again find that in your white blood cell, in your blood count report. So you'll get a platelet level there, and it's very important. Low platelets can cause problems. Low platelets basically prevent this clot from occurring. So this is a blood vessel wall, and there's some injury to the blood vessel wall, and normally you would have blood seeping out unless the platelets came here and got together and formed a plug that prevents the blood from seeping out by forming a clot. So the symptoms of having low platelets, you start getting bleeding. So you get nosebleeds, you get gum bleeds, you can get blood in the urine, you can get blood from the back passage. And that's very, very important to make sure that the medications are not causing low platelets. And the causes for low platelets, there are many causes. One very important for patients with PMR GCA, if you're on any immunosuppressive drug, sometimes these drugs actually can cause low platelets. So low platelets are something that's always to be contacted about. So some viral infections can also cause low platelets. So I won't go into the details, but overwhelming viral infections definitely can cause that. And we've talked about immunosuppressive drugs. People who are having chemotherapy can also get low platelets. So we now come to liver function tests. Okay, so the three important aspects of our monitoring tests. One is your blood count, one is your liver function test, and third is your kidney function. So we've talked about the blood count. Now we're going to talk about the liver function test. So the liver function test is very, very important. And really to explain why we do liver function tests in our patients, where in fact, actually some of the medications that we do give you, they need to be handled quite correctly, because some of these medications can cause liver problems, such as methotrexate, such as leflunomide. They rarely do it, but we need to be absolutely sanguine. We need to be reassured that the medications that we are giving you are not causing problems with the liver. And you may have other symptoms of gastrointestinal or liver diseases. Frequently, a common problem with the liver, such as, say, gallstones. So a lot of people may have gallstones in their gallbladder, and that causes inflammation, infection in the gallbladder, and then you start getting gastrointestinal or liver problems. Or, there are viral causes like hepatitis B, hepatitis C, or the less serious hepatitis A, and that can all cause changes in your liver function. Sometimes we do liver function tests because your liver imaging test was abnormal. And by that, I mean ultrasound, usually. That's the commonest liver imaging that we employ. And that gives us a lot of information as to whether the liver is normal, whether there are other changes in the liver, which we call, say, fatty liver, or whether there are changes of scarring in the liver. Sometimes we call that cirrhosis. Or we can also look for changes of inflammation in the liver, which we call hepatitis. Sometimes, of course, we find more serious causes of liver problems like cancer, etc. So all that is, we can get from liver imaging, such as ultrasound or a CT scan, and we will monitor the blood tests carefully in all these patients. And of course, a common problem is alcohol. And so alcohol has changes in the liver function tests, and particularly there's a test called gamma GT, which tends to go up, but you can also get changes in the different other blood tests, which we'll talk about in a second. So when you look at your liver function tests, these are the different things that we see. So we see bilirubin. And bilirubin, life is not simple. We look at whether the bilirubin is conjugated or unconjugated. Now, just to make it all very, very simple, the vast majority, of our bilirubin that we actually find on the blood test is unconjugated. 90% of the blood test with any bilirubin, that's due to unconjugated bilirubin. So that's not serious. It's only when you have rise in your conjugated bilirubin that tends to suggest that there may be a problem with the liver cells functioning. So that is the importance of bilirubin. In terms of the SGOT and SGPT, I won't give you the full names. Well, they're called transaminases. And this is something that doctors and nurses monitor very, very carefully in all our patients, whether they're on steroids, whether they're on methotrexate, leflunomide, or any other chemotherapy type of drugs, etc. So the first reaction that the liver cells have to any sort of changes due to inflammation, due to infection, due to drugs is basically a change in the SGOT or SGPT. Okay, so we look at these very, very carefully, and the normals are given here, but the normals can change in different labs. We also look at something called the alkaline phosphatase. The alkaline phosphatase, it can rise due to inflammation itself. So someone who's got very active PMR and GCA and has got raised inflammatory markers called CRP, they may also have rise in their alkaline phosphatase, but it tends not to be very high. Whereas if you have some sort of obstruction in the liver, which is preventing the bile, the liver produces bile, and that gets stored in the gallbladder. So if that biliary production is obstructed in some way by some obstructive pathology, and you get very, very high levels of alkaline phosphatase. So, but you can get alkaline phosphatase also rising in people who have liver cell injury. Okay, so that's your alkaline phosphatase. And finally, we come to the protein because all of these proteins that are found in the body are all produced by the liver. So the first sign of the fact that the liver is not performing very well is it stops producing albumin. Now, albumin is very, very important. It's relatively non-specific. So there are many types of liver damage that will give you a decrease in the albumin. But whenever we see a patient who's got low albumin, doctors, nurses, myself, Madeline, we get very, very concerned. So anyone who's got low albumin, it could be due to the liver not forming the albumin very well. It could be the kidneys that are pushing out all the albumin, but we immediately suspect that something is wrong. So that is an important aspect of albumin. And globulins, globulins are, when you have inflammation, you get rise in globulins. So when people come to us with active PMR, when people come to us with active GCA, the first thing that we see is actually their globulins have gone up. So whether it is rheumatoid arthritis, lupus, PMR, GCA, it just means active inflammation. So this is something, all these are the different things that we look at in your liver function test. I know I'm giving you a lot of data, but I'm sure I'm happy for this presentation to be shared so that you are able to scrutinize what I'm saying in when you have the time. Then we look at the kidneys. And of course, the three aspects again about the blood test that we talked about: the blood count, the liver test, and the kidneys. So kidneys are very, very important because ultimately all drugs, most drugs are handled, are excreted by your kidneys. They're either metabolized into inactive form by the liver and then excreted by the kidneys, or directly excreted by the kidneys. So the kidneys are the filters in your body. And if they don't filter very well, there's trouble. And therefore, we have tried in medical parlance to try and stage the amount of kidney damage that a patient may have. So if it is very trivial, if it is only up to 90% of the filtration rate, then normal, or, we say that's stage 1. If it is 60 to 90%, we say that it's mildly decreased function, and that's stage 2 chronic kidney disease. If there is more impairment, 30 to 60%, where mild to moderate decrease in function, and that's stage 3 of chronic kidney disease. If we see patients who've got more damage to their kidney function, to between 15 to 30%, that's stage 4. And these are patients with severely decreased function. And stage 5 is less than 15%. These are the patients who end up in dialysis. And all this is so important when we are choosing new medications to treat some of the disease, because we have to be constantly reminded that whatever prescription, and this is something that you may wish to remember when you see your GP, or emergency clinic, whether it's antibiotics, whether it's antihypertensives, you need to ask yourself, there's absolutely no harm in asking your GP, doctor, is my kidney function adequate? Because whatever drug that I'm being prescribed, ultimately it's going to be handled, filtered by your kidneys. So we therefore monitor what's called the serum creatinine. So you will find in your blood test results, urea and creatinine. The more important marker of kidney function is serum creatinine. And I really have to highlight the people who are at risk of having kidney damage. And these are the patients that we worry about whenever we give them new drugs. One is people with diabetes, particularly patients with insulin-dependent diabetes. But patients with diabetes tend to have some sort of compromise of their kidney function, and we are careful about that. Patients who have hypertension, patients who have raised blood pressure, they are more likely to have some compromise of the kidney function. So that's very important. Family history is very important. So if you've got people in your family who may have impaired kidney function, we are more cautious about using drugs that may damage the kidneys. The very fact that you're getting older makes you lose your filters, the cells in your kidneys. So older people have less filtering cells, which we call nephrons in the kidneys. And that causes some degree of impairment of renal function. So it's not that when we ask someone's age, how old are you, 75 or 65 or 85, it doesn't mean that we are being ageist. All it means is that the drug that we prescribe has to be handled by the kidney. So whether it is being handled by a 85-year-old kidney, 75-year-old kidney, 65-year-old kidney, or a 20-year-old kidney. So, and that's why we always ask the age before we prescribe any drug. People who have recurrent kidney infections are more liable to have kidney damage. And there are certain kidney toxic drugs that all patients with kidney problems or potential kidney problems should avoid. I want to make a point about avoiding anti-inflammatories. So anti-inflammatories in my book should not be taken chronically, should not be taken by the older individual on a long-term basis. If you take anti-inflammatories long-term, you're asking for big, big trouble with your kidneys, and they can damage their liver as well. So we need to be very, very careful when we are giving anti-inflammatories. One easy thing that now I've been recommending to all my patients is, we test the urine itself. And the urine test is done through what's called these multi-sticks. And these multi-sticks can be bought from the chemist. And it needs a little bit of effort to understand what these different colors mean, but these multi-sticks are absolutely vital because they give you huge amount of extra information. This is something that you could do in your home and check your urine or once a month or when you have urinary symptoms. And so when you use these multi-sticks and you dip the stick into your urine sample, you get an idea of whether there's any blood in the urine. So for example, you can make out whether the blood is 1+, 2+, or 3+, whether there's protein in the urine, 1+, 2+, 3+, whether there's any sugar in the urine, whether you're a diabetic, whether there's any infection in the urine, so whether there are any leukocytes or nitrites. So huge amount of information we just getting by dipping a stick and looking at the color change due to dipstick urine analysis. And of course, if you have any of these changes, then we further through doctors or nurses, we'll send it off for urine microscopy, and then we can tell you whether these changes are due to red cells, white cells, casts, and etc., etc. But this whole thing, whether you've got blood, protein, leukocytes, glucose, or nitrites, infection, is simple test, is the most important test for health or disease. Okay, now I'll come to the CRP. The CRP and the ESR is something very vital to all of you. And so let's talk a little bit more about the CRP. In our labs and all the labs across the world, anyone who's got a CRP less than 5, we are very happy. We are reassured that that person is not showing inflammation. So CRP less than 5 is completely normal. Now the ESR is a bit more complicated, and that's the reason in my unit at Southend, we virtually have stopped doing the ESR. It's because ESRs vary according to the age of the person. They go up in terms of age, and the older the person, you have a higher ESR. If you've eaten before you've had an ESR measured, you get a high ESR. So, I mean, I'm going to try and keep this message very short and very clear, is that we monitor the CRP. And the CRP is a very, very, very good test for PMR, GCA, large vessel vasculitis, or inflammation. There are different levels of CRP that we get involved with. For example, if you have a completely normal CRP that's less than 5, we are very happy. 6 to 10 is borderline. So we don't actually say that is inflammation or not inflammation. It tells us that we may need to repeat that at some stage. Above 10, we think it is elevated. And above 25, we think the CRP is significantly elevated. And very high levels of CRP usually accompany infection. So if you have CRP in 3 figures, 100, 150, 200, 300, yeah, the first thing that you need to exclude is infection. So, and this chest infection or urinary infection, these are the common causes of infection. So in the older person, if there's infection, we generally look at whether it's in the chest or is in the water. And that's why those sticks are so useful to look up a urinary infection. You can actually get severe inflammation causing rise in CRP, and GCA, PMR, rheumatoid arthritis, all of these are important causes of rise in the CRP. But important thing for all our patients with PMR or GCA is that when you face a rise in the CRP, don't jump to the fact that this is due to the PMR or the GCA itself. Do think of infection and other causes before we say that this is all GCA or PMR. So ESR, as I said, is a very reliable method, but if it is done by something called the Westergren method. But most NHS trusts now don't do ESR by the Westergren method, and it's not comparable in different hospitals. So really, we have gone to using the CRP mainly for monitoring our patients. One important message that I need to leave you with: there is absolutely no need for frequent checks. And I come across regularly patients who have their blood tests, their ESR checked every 2 weeks. Totally unnecessary. And once the PMR or GCA is stable, you just need blood tests every 3 months or 6 months, as the doctors mentioned, doctors and nurses. So finally, a few rheumatological tests that we don't do for PMR GCA, but these are the tests that we look for to screen other conditions, and you will find in your results. We do something called ANCHOR. ANCHOR is a test that we look for in other forms of vasculitis. So you will find that we may be asking for an ANCHOR. We do an ANA, that's an anti-nuclear antibody test, and that we do for lupus and other connective tissue diseases, such as a condition called Sjogren's syndrome. So that's the anti-nuclear antibody. We do the rheumatoid factor check for rheumatoid arthritis or other connective tissue diseases. We do something called an anti-CCP, and that's a very specific test for rheumatoid arthritis. So someone who's got anti-CCP positive in a significant level has rheumatoid arthritis. Of course, the uric acid is something that we always check out, and that can rise in gout, but it is also a marker of any sort of impairment in kidney function. So these are very common tests that we do in the rheumatology clinic. Blood tests cannot be completed without talking about the lipids. and lipids are a very important aspect of health or disease. So whenever you have your lipids done, so there are two ways you can do the lipids. One is fasting lipids, which is the more accurate way. So basically fasting after 12 midnight, and you have the blood test at 9 o'clock. So that's the ideal fasting lipid that we generally ask for. But even otherwise, random lipids can be very helpful. So we look at, if you ask for a lipid test, we get, these are the results. So you'll get total cholesterol. So total cholesterol in our labs, in the NHS, this is millimoles per deciliter. So anything below 5 or 5.2, we are quite happy with. So anything more than 6.2, we get quite worried, and patients may need other treatment for that. Now, cholesterol is made up of good cholesterol or bad cholesterol. A very simple, LDL cholesterol is bad cholesterol, HDL cholesterol is good cholesterol. So whenever you look at these results, LDL, HDL, what you want is your HDL to be high. So higher your HDL, you are well protected. Higher your LDL, you are badly protected. So you want your LDL to be low, less than 3.36. You want your HDL to be high, and it should be higher than 1.55. Okay, so any changes here, will make you start thinking of giving the patient more treatment. So basically, you want your LDL cholesterol less than 3.36 and the HDL cholesterol to be more than 1.55. And we calculate that as a simple ratio. So basically, we divide the LDL level with the HDL level. So any ratio more than 3 is dangerous, is worrying. Any ratio less than 3 is fine. So it's the ratio of your good cholesterol to bad cholesterol should be less, ratio of bad cholesterol to good cholesterol should be less than 3. We also mention the triglycerides, and triglycerides are something that we check, and certainly they should be less than 1.69. And I won't go into the more details of these others. So, again, I've underlined all this. So total cholesterol less than 5.2, LDL cholesterol less than 3.4, HDL cholesterol should be as high as possible, and triglycerides should be less than 2.3. So this is my last slide, and really these are my final messages. So you need, in this particular pandemic, but generally as well, you need to understand your condition. You need to understand PMR, GCA, large vessel vasculitis. But it's not just that. You need to understand the context, whether you have any other medical conditions, which we doctors and nurses call comorbidities. Whether you have diabetes, whether you have lung problems, heart problems, any kidney problems, these are called comorbidities. And so you need to understand the interaction of your condition with these comorbidities. You need to understand your medications, each one of them, what they're doing, what you're taking it for, and make sure that you don't end up with polypharmacy, because most of you older patients, a 70-year-old patient will have a 70-year-old kidney, 70-year-old liver. A 90-year-old patient will have a 90-year-old kidney, 90-year-old liver. So you need to understand your medications well. You need to have the steroids at the right effective dose, not 1 milligram more, not 1 milligram less. And that's absolutely vital. Please get a blood pressure machine, check it monthly. Please, you should be able to look at your urine dipstick. Again, I think a monthly test would be very good. Try and approach your GP surgery so that you get an electronic login to your records, so that you can visualize your blood test results and download your blood tests and look at what they're doing. You need to understand your blood test results, what we have been trying to do this hour today, and prepare carefully for your appointments, reviews, write down your questions, and be able to do all the things that the doctor or nurse may ask you to do in terms of finding out whether the disease is active. You need to maintain physical fitness, and this is absolutely vital, regular walking and optimal weight. And this is really, you must avoid any form of frailty. Regular joint exercises, range of motion, shoulders, hips, and do sleep well. We don't talk about sleep in the clinic, but I feel sleep is an absolutely fantastic marker of health. And finally, mental health is under such a challenge today in the pandemic, but even otherwise. So you need to try and find hobbies or a frame of mind that makes you remain happy and not concentrate just on the disease, because anxiety itself becomes your best enemy, because anxiety can cause headaches, anxiety can cause muscle pains, and then you react by increasing your steroids, and then you get side effects, which absolutely totally unnecessary. So mental health, non-anxious, good restful sleep is absolutely vital to your physical health. So that's my last slide. Very happy to take any questions. So Chris, shall I go through the chat, or do you want to go through it? And
if you've got vision of the chat, there are 4 questions at the bottom there. Do you want to answer them?
Let me stop sharing first. Yeah, I've got them here. So, yeah. So, shall I start from the last one?
Yep.
Okay. So, should we have? The last one's become the second last one. Should we have the flu jab if we have PMR GCA? Absolutely. You must have your flu jab as soon as it's available. So I can't recommend more strongly how important this year is for you to have the flu jab. Absolutely vital. You may wish to have the pneumonia jab as well, the Pneumovax, and try and, normally the NHS is a bit stringent about who they give the Pneumovax to, but I think the Pneumovax is becoming easier to get. So absolutely, you must have your flu jab if you have PMR GCA. Could you comment on advice given to me by rheumatologists to stop taking methotrexate if I get COVID-19? Very good question. So if you, in this pandemic, if you, thankfully, if you are free of this viral infection, don't have to change anything. Just continue taking your methotrexate, take the steroid at the lowest drug that's level that is required, and you don't need to come off them. If you get COVID, you must stop methotrexate, absolutely. And once you've recovered, maybe 2 weeks later, you can start it again. The steroid dosage, you may want to keep it at the same level or even increase it a little bit if you get COVID. There's some evidence that actually COVID-19 infection, particularly pneumonia, actually responds very well to some steroid. So there's no problem with steroids. The third question, by the way, I didn't mention the names. So Helen Marquis asked the question about the methotrexate. We've had from R. Hackney the question about the flu jab. I do have another one that has appeared bottom, but I'm going up now. So Jean Ando asks, how do you get electronic login to your records? Just ask the receptionist in your surgery. The NHS has promised to give all patients access to their health records. And some surgeries have been more proactive than others. And you may find that there might be some difficulties. So, and not all surgeries have that access. But I recommend that you start with asking the receptionist. So please do go and ask the receptionist to get you, it's called System Online, electronic login. And then you'll have to get of course, your password, etc. So do try. From Barbara, what should ESR be? Okay, well, we talked about that. ESR changes according to age, according to gender, according to what you've eaten, etc. So really, anything less than 30, we don't worry about. Even above 30, if the CRP is normal, I don't worry too much about it. So, try and get your GP to get your CRP done. So ESR is a slightly variable feast, really, according to what method of ESR determination we do. Sandra, where are we? Yeah, what exactly is inflammation? Sandra is asking. So that's a very good point. At the risk of boring everyone here. So essentially, I'll tell you how we get inflammation. So PMR and GCA are inflammatory diseases. So is rheumatoid arthritis. So what happens is, we don't know what's the first step, but these cells called the T cells and the B cells, which are the white blood cells, are triggered. And these cells then are producing the inflammation. So they trigger another set of cells called the monocytes and the macrophages. And these cells, they liberate a particular chemical molecule, which we call interleukin. And these interleukins, particularly interleukin 6, then stimulates the liver to produce the CRP, inflammation, ESR. So it's the inflammatory cells in our blood vessels or in our joints or in the different parts of the body then cause the inflammation of that particular organ. So you may have inflammation of the joints in rheumatoid arthritis. You can get inflammation of the arteries that we call GCA. And these inflammatory cells from these arteries over the temporal arteries can go into the heart and into the aorta and the large vessels. And then we get large vessel vasculitis. Or you can get inflammation, say, in the glands. And you can get in Sjogren's syndrome, or in lupus, you get inflammation of the kidneys, which is a very dangerous thing. Or you can get inflammation in the lung. So wherever you have inflammatory cells, you can get inflammation in the brain. And so that's how we treat. So all these medications that we use, steroids or other immunosuppressives, are usually used for inflammation. Christopher, okay, Christopher's questions about the chat. Okay, Christopher Poole to everyone else. From Gillian, I feel I'm having flares, but my ESR, CRP have come back to normal. I have been off prednisolone for a year after being on it for 6 years. Well, my answer to that, Gillian, first of all, is that symptoms don't equate to flares. So, for example, you may get aches and pains in your joints or your muscles or your spine. And sometimes, we are all older people, and we are all vulnerable to wear and tear changes. I often find myself very stiff when I try and get up in the morning. And that's more due to my osteoarthritis. And so aches and pains in the knees and in the spine quite often may be due to osteoarthritis. And yet they may be quite significant. But the important thing is then to differentiate that from the PMR and use simple paracetamol or regular exercises, strengthening your back muscles. But one of the things, you tend to get wear and tear pain regularly after a certain time period. And it's a good idea not to straight go back onto steroids. So not to diagnose your muscle pain as PMR and to increase steroids, not to diagnose your headache as GCA and to increase steroids. And there are, just like different causes of muscle pain, there are different causes of headaches. And you know, I really caution in terms of interpreting all your symptoms as due to PMR or GCA. From Pat to everyone, my GP tests plasma viscosity as well as CRP. Can you explain plasma viscosity? Of course I can. You know, plasma viscosity is just looking at a particular physical condition of the blood, how viscous the blood is, how viscous the plasma is. Now, if you have more of the CRP, more of the inflammatory proteins, the blood becomes more viscous. So plasma viscosity increases. So in many ways, plasma viscosity is a simpler, sometimes a cheaper way of determining whether you have inflammation. So if the blood becomes more viscous, the interpretation is therefore you've got more inflammation. But it is less specific than the CRP. And I generally, you know, NHS trusts do plasma viscosity purely for expense. It's cheaper than CRP. But although it gives you some evidence of inflammation, but it is not nowhere as sophisticated as the CRP levels. So I really think that because if your GP has access to the CRP, you can feel free to tell them, the GP, that Professor Dasgupta prefers the CRP, because it's so important to actually have a good idea of how much inflammation is going on. So from Dorothy, a question, GFR of 45 seems low, but GP not concerned. No one has mentioned fatigue, which I find more debilitating sometimes than the pain. Very good points, Dorothy. GFR of 45, well, I mean, the problem is that, you know, all of us tend to start getting some reduction in kidney function with age. And GFR of 45 in that sense doesn't worry us too much, so long as it's not causing any major problems. You know, any GFR above 60, we are happy with. And 45 definitely, in my opinion, should be interpreted as some impairment of kidney function, moderate. And it is important when you use drugs. So you need to use medications which are safe. There's no doubt that GFR of 45 is impaired renal function. But what I'm trying to say is that, to reassure you, is, you know, it's not the end of the world. And many patients do have a moderate, chronic, long-standing, unchanging reduction in GFR, which they're more than happy to live with. But make sure that your blood pressure is right. Make sure that your urine is free of infection. Now, your second question is fatigue. Now, fatigue can be due to the illness itself. It can be due to the steroids, or it can be due to a mental state of mind, which is an end product of all of that. So high inflammation can give rise to fatigue. So we do use fatigue as a feature of high inflammation. But fatigue can also relate to a lot of steroids. And steroids definitely have an effect on fatigue levels. So too much steroids, again, can cause fatigue. The most important cause of fatigue that I find is that actually the illness itself and the physical state and the mental state actually then causes poor sleep, poor non-restful sleep. And most of my patients find that first thing in the morning, they're not rested. So they haven't actually had any rest from their night's sleep, and they feel that they're tired. So fatigue has got different causes. And it can cause central fatigue. So your brain can be very tired. Then you get the brain fog, you get the concentration problem, memory problems, or you can get physical fatigue. So fatigue is quite a complicated thing. And whenever our patients talk about fatigue, we go into the depths to find out, is it due to inflammation? Is it the drug? Or is it some lifestyle problem like sleep? And then there's a question from Bonnie. Do you talk in terms of cure or just remission? So we don't have a cure. I mean, very few things can be cured. I mean, there are self-limited things that can be cured, but vast things we can only control. So yeah, we can control PMR, we can control GCA very well to put people into remission. But I can't claim that after stopping medications, everything will be right as rain. So, but we do see that in some patients. So largely we talk about remission. In small numbers, we can cure. Yes, so these are some of the questions. I don't know, have I missed any questions, Chris?
I can't see any that you've missed there, Professor.
Okay, so maybe I'll
say one thing before you start to close down. Don't forget to stop the recording.
let me do that now, actually.
It's a common fault.
Okay, well, I'll do that. Yeah, stopped.